Hello, my name is Dr. Shanda Blackmon. Welcome to the Baylor College of Medicine Lung Institute podcast series. We're here to communicate with all of our care providers, our learners, and our community, as well as patients, about how to improve lung health, how to educate you and all of the people around you about ways to prevent lung disease, treat lung disease, and maintain lung health. Hello and welcome to the Baylor College of Medicine Lung Institute on-air podcast. Today I'm here with Dr. Siddiqui, who runs our radiation oncology program, mostly for patients with lung cancer here, participating in our multidisciplinary lung tumor board, participating in our radiation oncology program here at Baylor College of Medicine, and providing support for all different kinds of patients who might need radiation therapy for all diseases, but primarily for patients with pleural, lung, or some type of thoracic problem. Welcome, Dr. Siddiqui. How are you?
I'm doing good. Thanks for having me on the podcast.
Yeah, it's great to have you here. So tell me a little bit about your background and what brought you here and why you're so passionate about radiation oncology.
Yeah, so growing up, I loved physics and I loved medicine. And as I was exploring different fields, cancer medicine really became one of those focuses for me. I saw the very deep conversations that patients had. The appointments were not every 10 minutes, they were every hour or half hour, and that reflects kind of how much we put into patient education and patient counseling. So that was very meaningful to me. Radiation employs some of the best technological advances that we have in engineering to help patients, and that really spoke to me as well. So I did my medical school in Chicago, and then I went to Michigan for training. And then after that, I had another position at an academic center before coming to Baylor, but I was really pleased with the multidisciplinary care here and the ability to work with experts in surgical, medical oncology, and other fields. So.
Great. So we've seen a lot of advances and changes in lung cancer care, specifically for patients who present with primary lung cancer. Can you talk to me a little bit about what you see the landscape changing? Specifically, we've had a lot of chemo immunotherapy trials. We've had a lot of, the Pacific trials come out, the multiple checkmate trials have come out, and the Adura trial. Now what we're seeing is a lot of patients are getting more chemotherapy, chemoimmunotherapy, or targeted therapy, and then they're getting surgery. And radiation is now maybe a little bit more amorphous, but we also now have SBRT. And we know that some patients are better served with radiation than surgery, sometimes if they're too high risk for surgery. Talk to me a little bit about how you navigate through all these different clinical trials and help patients make good decisions.
Yeah, absolutely. So the advances in surgery and medical oncology have helped lung cancer patients quite a bit. And, we find an evolving role for radiation, certainly. And like you said, I think radiation currently plays a role as an alternative to surgery for patients who can't get it. So I like to think of lung cancer as early stage or locally advanced. That's kind of how we talk about it in tumor board as well. Mm-hmm. And for early stage lung cancer, surgery is often a great option, but for patients who can't get surgery due to their medical conditions, we can offer this technique called SBRT. And SBRT kind of utilizes some of the latest advances in radiation.
And SBRT stands for?
Yes, stereotactic body radiotherapy. Yeah. And most of those words may be a little complicated, but stereotactic just means very precise. And surgeons also use stereotaxy in the OR, but we use it to localize precisely where the tumors are in the body. Mm-hmm. Maybe 30, 40 years ago, when we gave radiation, it was based on plain film X-ray. So we just point a beam and hope to hit the target. And now we actually have CT scans on our machines that can even track patients' breathing motion. Okay. So we can really precisely target those tumors.
Great. And I remember about 20 years ago, I used to have to place something like a gold seed. We call it a fiducial for what most people in the city of Houston were using, which was a program called CyberKnife. And then we had Sabre and other technology that came out, different platforms that would allow us to radiate the patient and track things without having to have an internal piece of gold seed or marker or fiducial, which is what we call the gold seed, to track and mark the tumor. So how has that changed?
Absolutely. So the reason for that seed was because we did not have cone beam or CT scans on our machines initially. It is still used even with CT scans at some centers, but many centers have become comfortable with using onboard CT guidance to replace that gold seed because we can actually see the tumor right before treatment. That process is still being refined. Oftentimes we just kind of blur the motion of the tumor with breathing and so treat a little bit larger of an area than we need to. There's different techniques to kind of freeze the tumor in place or to track it with our machine. CyberKnife is really good at tracking, and some of our Linac systems are also catching up with that technology as well.
Great. And can you talk to me a little bit about the difference between proton radiation and photon radiation?
Yeah. So both are high energy beams that are non-invasive. The patient is lying on a table and a machine is delivering this beam of high energy to damage tissue. Both protons and X-rays damage all the tissue in their path. The difference is that protons' path stops right at the end of where we mark the path to stop, so at the end of the tumor, versus photons kind of diffuse like a spotlight on a stage. Protons have been studied for many different cancers. In lung cancer, there's been some trials that have shown potential reduced toxicity, but nothing definitive. There's some other thoracic cancers like esophageal where that benefit is a little bit higher, or thymoma, which is a little bit more of a rare thoracic cancer. But for lung cancer, for the most part, we're using our SBRT technology for early stage or IMRT for advanced cancers.
Okay, so just summary, this podcast is for patients as well as providers, but probably not providers who are deep into the science of treating lung cancer. So I want to make sure our audience really gets a good sense of what's happening. So the different types of stereotactic radiation can be for patients who are not a good lung cancer candidate, even for early lung cancer. So if someone has smoked their whole life and they have very little reserve and we don't even think they would tolerate a wedge resection, then we send them to you and you might do SBRT if it's early stage lung cancer. If someone's had a pneumonectomy, which means the whole side of one lung's been removed and they have a new early lung cancer on the other side that's separate from the one that they might have had on the side that required the pneumonectomy, then that patient might be an ideal candidate. I think of people that we just don't want to operate on at all, those are clearly the ones that we make sure that they get to you. And then there are those people in the middle, and I think that's where Tumor Board really plays a great role. Sometimes this is a conversation between the two of us or a conversation within our Tumor Board where we sit down and we talk about what's the best need to meet the patient. So what do you see happening with the chemotherapy combined with immunotherapy or combined with targeted therapy? How do you see that landscape changing your role for radiation oncology?
Yeah, so for advanced lung cancer, as you mentioned, the Pacific trial showed a strong role for immunotherapy after radiation. And so all of our patients who are getting radiation and chemotherapy for stage 3 non-operable lung cancer get immunotherapy afterwards if they're good candidates. And there's been a push in the surgical space to try immunotherapy before, which hasn't really been replicated in radiation. But there's certainly some trials and thoughts out there to better incorporate chemo and immunotherapy with radiation. We did try a trial with immunotherapy with radiation. Some of those trials were negative. So we're still trying to figure out if there's a better way than just tacking it on to the end of a patient's treatment course. And then for early stage lung cancer, there have been just a few early trials for immunotherapy, but nothing definitive that has changed kind of the standard of care. So we still rely on our medical oncology colleagues to guide some of that decision making on a case-by-case basis.
And then I always hear radiation oncologists maybe even 10 years ago, talking about this concept of abscopal effect. And now that we have some clinical trials of even injecting immunotherapy into the tumor for advanced stage lung cancer to try to stimulate the immune system, and then doing something to that tumor at the same time, whether it's electroporation or some type of energy source delivered to the tumor to disrupt the tumor and expose the antigens and allow the body to start to react against the tumor, and then giving the patient immunotherapy to augment that immune response. Tell me a little bit about what your thoughts are on abscopal effect and whether or not you think it's real, and if you think there's any science behind it.
Absolutely. So the abscopal effect and studies on the abscopal effect predate even immunotherapy. People started noticing that patients who had multiple tumors, let's say the lung cancer had spread, we would radiate one spot, and in a very small minority of patients, they would actually have shrinkage of the tumors in sites away from where we radiated. So we're radiating the lung and their bone mets shrink, or we radiate the bone and their lung cancer shrinks. And so this was a very strange effect. And eventually it was found out that this was because the immune system of the patient reacted in a certain way to the radiation. The exact mechanism is not really known, it's under study, but what we think is that radiation damages the cells and causes the internal contents of cancer cells to be exposed. Usually they're hiding from the immune system, and when we damage with radiation, some of those flags that are within the cancer cell are exposed to the immune system all of a sudden, allowing the immune system to make that response. And now in the immunotherapy era, there's been a lot of excitement over the abscopal effect to see can radiation really cause this in a bigger chunk of patients, whereas before it was happening only in a couple % of patients at best. Can we really use immunotherapy plus radiation in metastatic cancer patients to control tumors better? So far, the evidence points to the fact that every site needs radiation or some kind of local treatment to really be effective. But obviously immunotherapy is also in its infancy. There's still new drugs coming out every year targeting different immune pathways. So maybe with further advances, we can combine them with radiation more meaningfully.
Well, that makes sense. And so we've talked a little bit about early lung cancer and where radiation therapy might or might not play a role. And then we've talked about locally advanced. And then the last category that we haven't even touched on is metastatic. Mm-hmm. Sometimes patients present with a metastatic tumor to the brain or the bone. And those are areas where we really do believe that radiation is sometimes leading the way that we intervene. I know that for most part, patients get radiation therapy to metastases when they're symptomatic from those metastases to sort of palliate them. Can you talk a little bit about what that is and how you think radiation plays a role?
Absolutely. So radiation for palliation is a very important part of cancer care, and it's one of the most common reasons why we see patients in our clinic. Patients often present with painful lesions in lung cancer, whether that's in the bone or even soft tissue lesions, and people have studied extensively the role of radiation. Either a single shot of radiation, which is convenient for the patient, can cause a pretty decent pain response and improvement in pain, and also a reduction of opioids. A lot of cancer patients need narcotic pain medication because of the severity of their pain. And we find that the quality of life improves when we can treat with radiation and reduce that dependence on narcotic pain medicine.
Yeah, that makes sense. I mean, I think we want to do everything we can to lower the opioid addiction crisis that we're facing in the United States. And finding a way to have a multidisciplinary, collaborative approach to even palliative care here is so important, especially for our cancer patients.
And you also mentioned brain, and I'll throw in their spine as well. So even without necessarily having symptoms, brain is one of those spots where symptoms can develop really fast. So we often see patients very early for brain metastases. Mm-hmm. And we treat them with advanced stereotactic radiation, again, to target the tumors in the brain that may be from the lung cancer without disrupting too much normal brain tissue. The spine, likewise, spine metastases can cause a lot of morbidity, a lot of illness for the patient, especially if a fracture happens in the spine. So we try to stay ahead of those metastases as well by treating them, and we, again, see a greater role of stereotaxis for that. Whereas before, every palliative radiation used to be more of a simple plan. Now we're doing very precise plans even for palliative patients so that they can maintain their quality of life.
Yeah, and that brings to light sort of that middle zone between metastatic disease and locally advanced disease, what we call oligometastatic lung cancer. And that's where you have metastatic disease and you have primary lung cancer, but it's just a single site of metastasis or one or two sites. And we know that the MD Anderson group did a great job looking at that and publishing their data on early oligometastatic disease and treating everyone with some type of ablative therapy, whether it was surgery or radiation therapy. And so tell me a little bit about how you navigate that.
Yeah, and that's where the multidisciplinary tumor board is very important. So historically, we've started with systemic therapy for everybody with metastases, whether they were very metastatic or a little bit metastatic, so-called oligometastatic disease. And for many patients, that's still the right approach, is to start with chemotherapy, immunotherapy, targeted therapy, something that can control all the tumors in the body, hopefully. But we are seeing an earlier integration of local treatment, whether that's with surgery for the primary site or with radiation to the primary site and to metastatic sites. So often, and this is actually becoming a larger part of my clinic now, where we see patients who have 1 to 3 or 1 to 5 metastases. They get some systemic therapy. After their first several rounds of systemic therapy, they get sent back to me to be considered for treatment with radiation to the primary lung cancer and to all metastatic sites. And the data shows that it actually helps control the cancer for longer. So that's very promising for our patients as well.
Well, and I always appreciate the collaborative approach in tumor board. It's always wonderful to learn from our colleagues and learn how the other specialty works. It makes us better surgeons and probably makes you a better radiation oncologist to learn how the surgeons think.
Absolutely, absolutely.
So what do you think is coming down in the future? How do you see the pipeline of patients coming through with lung cancer and other thoracic cancers? Anything that you can predict, or what are you most excited about?
Yeah, I think there's two things that I'm excited about. One is AI, which everybody is excited about, but it has the promise of giving more personalized treatment to patients. If you look at how cancer is treated, and lung cancer even specifically, they're broad sort of, patients are categorized in relatively broad categories and treated in similar ways, even though every patient is actually unique. So really that uniqueness is up to the physician to provide at this point in time, where you have multidisciplinary discussions. You have that conversation with the patient about what's important in their life. Is it quality of life? Is it beating the cancer for as long as they can? How is their family going to support them? So that really depends on the physician. And I think AI can play a role in that personalization as well, especially when it comes to the biology of the cancer and understanding how it's responding earlier. So we have some studies that are looking at AI analysis of lung tumors during radiation, right? Can we change the radiation plan while the radiation is ongoing to better personalize the treatment? So that kind of personalization is key, and I think AI can play a role in that. And I'm involved in some of the studies for imaging-based AI for lung cancer as well. I think long-term it's going to be about keeping the patient in the center of the focus. All of these advances mean more if it really helps patients get connected to care and incorporate that care easily in their life. So for radiation specifically, a lot of patients have difficulty with the simple fact of coming back and forth for 30 treatments. That is a hard thing to do. That's putting their life, turning their lives upside down, basically. And if we can reduce the number of treatments, which many trials have done and continue to do in the future, or just make it more convenient for the patient, reduce their symptoms from radiation, that's going to play a key role in making sure that patients live healthier lives after the diagnosis of lung cancer.
Yeah, well, I have to say I'm so pleased to hear you working on keeping the patient in the center of the conversation, leveraging AI and other technology, and really staying on the forefront. I'm aware of some of your research, and I think it's really exciting, and I can't wait to see what you find. Thanks for joining us today.
Yeah, thank you for having me.
Yeah. Thank you so much for joining us for the On-Air Lung Podcast at Baylor College of Medicine Lung Institute with Dr. Siddiqui. you can call 713-798-LUNG, and that will get you to our service, which will reach out to you within 24 hours if you have any questions or concerns about patients with lung malignancy or any type of lung cancer. Thank you so much for joining us. Have a great day.